Good morning, everyone. Welcome to the third edition of the Boomi Health Talks. We're going to wait a little bit for all participants to join us. We're going to be talking about glaucoma. So, as I mentioned, we're going to be talking about glaucoma, the silent fifth of sight, which is much more common than we have thought. And it is important to have a great treatment and prevention. We're going to wait another minute so that we can have everyone connected, all the participants or attendees connected. Okay. So these are some comments prior to the webinar. The sessions, as you can see, are done in Spanish, but there will be a simultaneous interpretation into English and Portuguese. This is something that you may find on the Zoom toolbar. These are going to be the instructions for you to benefit from this. So, how to use the interpretation? You can hit click on the meeting controls uh, button. There is a globe and it says interpretation, and you can select the language that you want to hear on this that you want to hear. You can hear it in Spanish, but you also have the option to listen to this in English and Portuguese. So you know that you can gain access to this option with your computer. And allow me to introduce myself. My name is Miguel. This is the third edition. I am responsible for the telemedicine and health program of BUMI. This is one of the most important strategies, and it is adding value to everyone. I and I will be here with you in the webinar and in the Q&A session. And and in the controls, you can also find the button that you can find where you can find the Q&A, where you can proceed and ask the questions to the doctor to during the webinar, and then at the end we will be responding to all the questions that we find there. Without any further ado, today I want to introduce Ana Maria Medina Botero. She is an international business and marketing leader with more than 8 years of experience. She manages the international office of Sura Colombia, redefining the global expansion of the business lines. Her approach combines data-driven strategies with emotional intelligence to influence decisions across different cultures. She has developed successful business strategies in key markets such as the US, Central America, and the Caribbean. I'll pass the floor to Ana Maria. Thank you, Ana Maria, for being here with us. No, thank you. Thank you, Bumi, for this invitation. We're very pleased. Sura is a company that has been working for over 35 years to develop a health ecosystem in Colombia that allowed us to become an authority. Today, 35 years after, we have more than 6 million clients in health, and we serve 100 million services of medicine per year. So this is the best provision of services in Colombia, and it stands out as one of the countries where we have more progress. We have three hospitals among the top 100. Three of those. of those Colombian, and this speaks about the health characteristics in Colombia. Today, we are booming all like to find the best of the best for the patients, and today I am very proud to introduce one of the clinics which are part of the network. Today we have Jose Francisco Bernal, who is the uh, partner of the ophthalmology clinic. They have done an amazing job on international accreditation to follow the same standards globally. Francisco, thank you for being here. Uh, Thank you for the intro. My name is Jose Francisco Bernal Marquez. I am the I am a partner in the ophthalmology clinic. We have been operating in Medellin for 18 years. We have the PHA certification for outstanding experience. We are the only clinic. We have been working strongly in quality standards for laser strategies in advanced medicine. So we have had already 140,000 surgeries in our process. At this time, we have zero infections and zero point 0.3. So this is ranking us in a very interesting indicator globally. So I want to introduce Dr. Laura Romero. She's a glaucoma expert, 5 years with experience clinical. She conducts SLT surgeries, and she has vast experience in the area. So welcome, Dr. Laura. Good morning. Okay, so I'm going to share my screen right now. Great. Okay, so we're going to be talking about glaucoma. This is a very important disease, rarely known, and especially where we have had a lot of experience in the clinic with the significant amount of patients and surgeries made. When we talk about glaucoma, we shouldn't talk about just a specific disease, and they affect the eye optical nerve in the neck. What happens there is the programmed death, which are the ganglion cells. These occurs progressively, gradually. Therefore, in the vast majority of the cases, there are no symptoms, so there's no way for the patient to know that he or she is suffering this disease or illness. So this is why it is known as the silent enemy. It is important to talk about glaucoma because this is the second cause of blindness globally. And when we talk about the first cause of blindness, irreversible, we need to talk about glaucoma, the second cause in general terms. And when we talk about blindness, that is not something that can be cured. In 2020, 3.6 million people over 15 years old were blind due to glaucoma, and 4.1 million had some were moderate to severe visual impairment. So within the different types of glaucoma, which is something that I will be mentioning, the most common on the Western world is the one called is the open angle primary glaucoma, which is important in the Caribbean and the Antilles. In 31.7 persons suffer blindness due to glaucoma in Saint Lucia. uh, with the Black population, 8.8% of those persons were blind due to glaucoma. In Colombia, and specifically in the clinic in 2024, nearly four, we had we did 212 surgeries. So this is the importance of of this disease and or illness, and this is why it is important to talk about this, because as this illness increases, the quality of life of the patient decreases, and as I mentioned, this is silent and it occurs gradually. So let's talk about the anatomy and the mechanisms. What's happening in glaucoma? At the beginning of my speech, I said that glaucoma is affecting the optical nerve, and the optical nerve it affects the retina all the way to the occipital area of the brain. That's where we can see that it is affecting the the optical nerve. So this is why you are going to lose that connection. Apart from the optical nerve, I would like to highlight some structures. I don't know if you can see my cursor there. Can you see it? Perfect. These are some important structures. This is the iris that provides color to the eye. We're going to be talking about this later. And we also have the drainage angle, which is the one that we have seen, that we can see here. It looks in blue in the graphic. It is important because in the eye, there has to be a balance between the liquid, which is an aqueous liquid, and going in and out, so that the pressure, so that the intraocular pressure is normal within the regular angle. When there's a problem in this drainage angle, if there's a problem for the outflow, there's an increase, and there's a glaucoma suffered afterwards. So who are the persons having risk factors to suffer this type of illness? The first thing is that the most common factor of all the ones that I mentioned before is the ocular hypertension. The increase of hypertension is the most important risk factor, and this is the only one of these factors that we can modify. This is why the therapy of glaucoma manages ocular hypertension. There are others that I would like to mention, which is the family history. This also has an influence. If I have a family member with glaucoma, I can have 10 to 20% um, risk compared to others. And this is the cup to disc ratio, which refers to this hole that we can see on the bottom part, where we all have this, but in glaucoma, it increases its size, and it increases its size due to the loss of the nervous tissue. The neurons, which are part of the optical tissue, are getting lost, and this is why we can see the excavation. So this is an image of the same patient with 12 years of difference, we can see the nervous tissue vis-a-vis the other one, which is almost nil in photo B. So so we have this is a moderate, and due to a poor control, it progressed to a severe. Another factor is age. Although at any age you can have glaucoma, the main types of glaucoma that I will explain later on, they begin at the age of 50. Another factor that I would like to highlight is the black race. Glaucoma, for black patients, they are not duly diagnosed, and they can be more aggressive and harder to control. As to the as to as to eh, the different disease, the illnesses, there are uh, hypermetropy is associated to close angle glaucoma. So if we know what glaucoma is and why it takes place, and if we know which are the risk factors, why are patients going blind due to glaucoma? So this is quite complex, but in general terms, these are the three factors. Uh, this is to the treatment. This is not only due to the lack of knowledge of the disease, but the fact that it is asymptomatic in the vast majority. So if the patient feels good, or if they feel that that they can see good, they have no motivation to go to a preventive consultation. The other one is the low adherence to the treatment. It has to do with the cost, especially in our countries, because these are countries, because these medications have a very high cost, and this affects the economy of the patients. And the other one is education, since they feel good, since they are not aware of the disease and they feel good, so they do not pay attention uh, to the treatment or to use it every day, and this is why this is a disease that will progress. Now, the lack of follow-up, this also takes place due to the prior reason, which is education, but it may also be influenced um, by our health system, which make it hard to follow up. Another factor is the accelerated progression. Although glaucoma, there is a whole set of glaucoma. In this set of glaucomas, there are some of them that are more aggressive compared to others. For black people, makes it very aggressive and accelerated. And if we compare the open and closed drainage angle, the closed one uh, causes blindness faster compared to the open one. So talking about the classification, since this is a set of diseases that can be classified differently, we we can talk about we we have the open and closed angle, as I mentioned at the beginning. Some of them are acute or chronic. We have to clarify that that most of them are chronic. We can speak about acute, subacute, and chronic, and the acute and subacute are more associated to glaucomas that are associated to some diseases, or to the closed angle glaucomas, which may have a subacute angle. And the other way to classify it is the primary or secondary. The primary, which are not associated to other diseases or systemic diseases in the body, and the secondary ones, which are associated to maybe associated to diseases or traumas, or to the use of corticoids. So these are ways to classify this disease. So the primary glaucomas, this is how we classify them. We can have two angles. These are the most common, the ones that I'm including on the slide. The open angle, and which is associated with the short sight, the close, the angle, and which is also common for Asian people because it is associated to close to small eyes, and it also appears in Latinos. And then the children's, fortunately, is not too common, and in general terms, it is much more visual. There are some findings, and and it and and in the most of the cases, they can detect it in the first year of age. So we're gonna be talking about the symptoms. Some people are asymptomatic. The vast majority are asymptomatic. The patient will not notice this. What happens? You have a couple of things: the decreased contrast sensitivity, which takes place at the beginning of of the illness or disease. So, so these are 2 points that are separated, and they cannot see it in a different background, which is what we know as contrast. Since this is so subtle, the patient doesn't notice. And there's another one, and this is the blurred vision, and this is common because at the end of the day, the decrease progressively will lead to blindness. But these points, when we talk about headaches, uh, periocular pains, and the blurred visions, especially in the morning, those four are associated to acute glaucoma. When they are chronic, uh, they do not cause this type of symptoms. So how can we diagnose this type of disease or illness? The f- uh, the m- The first the first one is the clinical findings that we find in our consultation. We need to talk we need to talk about the different exams when the patient when we take the pressure of the eyes, and that's a risk factor which is very essential for the diagnosis but also for the progression of glaucoma. We also in the consultation we also need to assess the different angles if they're open, close, and we also need to look at the background of the eyes because we that's how we can see the optical nerve. So these are three photos. On the third one, we can see a patient with a moderate glaucoma. We see a pink, orange, nervous, optical nervous. We see an wide excavation. The first one, this is a glaucoma, a chronic glaucoma, but it's more advanced. We can see we see a nervous an optical nerve, and it is quite scarce. We see less tissue in the patient, so the excavation is quite extensive, and they are, and this atrophy that is very close to the optical nerve is looks uh, very chronic. Apart, if you look at the vessels here, they uh, uh, they are quite affected, so this implies a chronicle effect. So I left this one in the hat because this is an optical nerve that had acute um, a glaucoma, so it is not easy to determine where the nerve, the optical nerve is there is completely yellow, and and this is a bleeding that indicate that is talking about extensive fluctuation. So This is something that has to be addressed in the consultation, and this is going to give us an idea of how long has this patient had a glaucoma and what type of glaucoma this patient has. So we have different functional studies like the visual field. The visual field is this is this this is one of the oldest studies, and it is a golden standard for this. So the patient is showed some points in the in the unit, and and they push, so you can see a graph where the different points that are not seen, but the patient will be darker. The deeper, the higher the affectation. The visual, this is there are certain limitations to this. So in order for you to see the damage on the visual field, there has to be a loss of 25 to 50% of the ganglion cells. So there's a period of time where we didn't know where the disease was there. So the patients, there has to be a learning curve. So the suggestion at this time in the American and European literature is to have these special exams at least every 4 months. And the first three ones are the learning curve of the patient. So the following ones are compared to determine if there's progression. Another important study is the CT scan, the OCT. So what this does, it does an optical biopsy. Unlike the visual field, it does not depend on the patient. This is objective. It is very quick because with the visual field, patients get tired. For this one, in seconds, it can be done. It can be reproduced, and and it is quantitative. So it can affect the glaucoma damage before it is reflected in the visual scan. So we can detect them at the very beginning. We have a cutting edge technology at the clinic, and we're using it a lot to support our patients for diagnosis and the follow-up of glaucoma. The report, this is the report that produced by this equipment. It gives you whole numbers. It gives you the measurement of the ganglion cells. It measures the excavation and the size of the nerve. So there's a lot of information, and on the bottom part, it provides a curve and a graph. So it is quite dynamic and easy to understand and practical at the same time. So as to the treatment, this is a disease, this is irreversible. Uh, when we get to the diagnosis of this patient, this is not something that we can recover. But the objectives of the treatment are to control the target range, to maintain the target to avoid progression and to reduce the progression rate so that we can improve the quality of life. The This depends on the age, on the stage of the glaucoma. So everything will be important to define this target range where we need to maintain the pressure of this patient. So in order to comply with these objectives, we have medications, we have laser procedures, we also have surgery, which is minimum invasive of glaucoma, and with the traditional surgeries. So so these are the medications. These are the first line of treatment for the vast majority of glaucomas. We have the different types. or families of medications that we normally use. We have available to treat glaucoma. Of these, the first line are the prostaglandin analogs and the beta blockers because they reduce the progressant and they have a reduction of 70 to 85%, while the beta blockers can reduce 25%. We use them a lot, but they also have adverse effects which may be systemic. For example, in the beta blockers, they are not appropriate for people with asthma or any heart issue or cardiac issue or those patients with EPOC or heavy smokers. And the carbonic anhydrase inhibitors. And this is the first line. Although they don't have adverse events, they do have some local importance because they can cause red eyes or and they can affect the adherence of the patient to the treatment. They can change the iris color. They can increase eyelashes. Something else, we're talking about chronic use, and we're talking about chronic use medications, and some of them will affect the economy of the patients. We also have some options, and I'm going to be talking about the laser procedures. There are laser procedures that we can use uh, for therapy, and some of them are good to preventing patients that do not have glaucoma to try those risk factors that they have, uh, like iridotomy. As This is something that we do in patients with narrow angles. Uh, so what we normally do in this case is we use laser to do this hole, which communicates the rear chamber of the eye with the iris, because it will allow us to do this drainage. The iridotomy, this is one of the lasers that we can use to treat and to prevent. On the right hand, on the right side, we have the equipment that we have in the clinic. We use it for um, iridotomies and for selective laser medicine, and it has helped us a lot. We use it a lot. Used it a lot in 2024. We did 808 laser therapies to prevent and to treat. So this is a very important ally that we have. This is another laser. This is something. This is called iridoplasty, and it is used preventively. Unlike the iridotomy, where we do a single hole where we break the tissue to open a hole, and iridoplasty, we do not break the issue. What we do, we make it thinner, and this is done at 360 degrees to make sure that the iris tissue detracts so that we can find the drainage angle to facilitate the flow of the flow. So this is a cutting edge technology, and it's been a great ally for these patients. Another laser, which is a new technology compared to the ones that I mentioned, and that I really love it. I try to use it as much as I can because I've had the outcomes. Is the selective laser trabeculoplasty, so or the SLT. So what we do, unlike the other ones, is to act directly on the drainage angle. uh, where we this is the angle of drainage. So the laser gets there and it works. We we do like 50 or 60 shots and in drainage in the drainage to open the pores and to improve the outflow or the drainage at the same level of the drainage angle. One advantage that we have in the trabeculoplasty is that we can add it to the medical treatment. It is a first line treatment for the open primary for the youth glaucoma. We use it a lot and in the and in the secondary glaucomas. Another laser. But we also have the cyclophotocoagulation laser. Unlike the other ones that I have mentioned, it is done in the surgery room. But in this case, we're not going to improve the aqueous flow or liquid. But in this case, we're going to move on. This is in this case, we do a controlled destruction with laser so that we can reduce this obstruction. The intraocular pressure depends on the balance of the but it depends on the flow. So this is a laser that although it is done in the surgery room, it is not invasive. There is a probe uh, on the soft part of the eye, and it is appropriate for other types of glaucoma. The cyclophotocoagulation, we're going to use it in those patients where we have never had a response or where we didn't achieve the target pressure despite the medical treatment, despite the other lasers, or even despite the fact that this patient has been subjected to traditional surgeries. So this laser is appropriate for is appropriate for refractory glaucoma patients or those who are difficult to treat. The minimally invasive surgery, this is something that uh, came up at the end at the beginning of 2000. This is right for moderate to mild glaucoma patients where we're not getting to manage the target or who are young, who are having not such an advanced glaucoma to have a traditional glaucoma. So the advantages is that there is minimum trauma to the tissues. So therefore, their their recovery will be better. So these type of surgeries is quite common in the past few years. Everyone is talking about mix for the past few years, and these mixed technology is advancing a lot. There are many positive procedures, but it is for mild to moderate glaucoma. Now we have the filtering surgeries or the traditional surgeries. With them, we can improve the drainage. We're going to create an alternate drainage because the drainage is damaged or we're trying to act there and we're not getting to the intraocular pressure. So this is why this is where we have the filtering surgeries. The trabeculectomy is the one on the upper part that we create a communication, communication between the external part of the eyes, which is right uh, below this area, and the internal part of the eye will create some connection there because that's the new way for the aqueous humor to drain, and it is because it is not sufficient the drainage with With the valve implants, we're doing the same thing. We're creating communication between with the internal part of the eye through the device. In this case, uh, as we can see in the slide, this is a valve that is regulated. These traditional surgeries or filtering surgeries are effective to reduce intraocular pressure. They can achieve the greatest percentage of reduction of intraocular pressure. There are high complications, and the effect decreases with years. So this is why this is not the first line to treat glaucoma. So what are the indications when the target IOP is not reached with medications? And with the lasers that we mentioned, or with the minimum invasive surgery, our last option will be the filtering surgery when there's poor tolerance to medications. Medications are really good, but they can have adverse effects when there's low tolerance or when the patient cannot adhere, if it is due to education or due to the health system. When, despite having the medications or after doing the laser procedures, we see in the studies that the disease is progressing. So that's where we have the filtering surgery, or when we have a patient for the first time with a very advanced glaucoma. If they have a well advanced glaucoma, this is where the filtering surgery is suggested. So this is what I wanted to share with you. We're now moving on to the Q&A session. We're going to share. I'm going to stop sharing. Thank you so much, Doctor, for your presentation. Quite an interesting presentation, as usual. It is important to talk about these pathologies that are common, are really common. So we're going to move on with some questions from the from the audience. One of the questions is, as of what age should you uh, uh, try to discard the glaucoma? That's a very good question because we indicated that one of the main risk factors is age. So the recommendation is that as of 40, we should start the annual control with ophthalmology, especially if we have a family member with glaucoma in the first or second uh, level of kinship. What what's the influence of food in the progress of glaucoma? This is something that has been investigated quite often. For glaucoma, there is no medication having an epidemiology effect that will lead to this, such as in other pathologies where there's a clear relation. At some point in time, uh, it was said that certain food which are full of sodium could predisposed to the movement of the iris in patients with closed angle glaucoma. But these are things that are not having such an epidemiology burden. What pathologies do have to do with this? Pathologies like diabetic retinopathy, and for the uh, and also this is related to age. It's been said that that a diet, our Western diets, are not protecting us from these macular degeneration. So in terms of food, or consumption, things are not too clear.
Like,
When there's a dry eye, not really, but the dry eye is so important because the dry eye can lead my glaucoma patient not to be adherent to the treatment, or the chronic use of some drops can worsen the dry eye in these susceptible patients, and it will compromise adherence, and this will be predisposing to this disease. Thank you. I think that this you already responded to this question. We can have a response. What are the symptoms? The most common symptoms, talking about something more specific. When can I have this type of warning after the age of 40? I mean, things are doing good and there are no issues, but what can be like a wake up call so that I can do a checkup before the age of 40? That's a good question. We as Latinos, we have a significant population with closed angle glaucoma. And in general terms, there's a subacute effect. So it's a warning sign. So see, if I have headaches when I wake up in the morning, that's something that will lead me to find or to get the medical support. If I have or if I have effects on on the vessels, and I can say, well, why do I have these vessels bleeding? This could be a warning sign in patients having glaucoma, or who didn't know this, or who had their close angle. So blurred vision when I wake up, and which becomes clear along the day. So these may be a subacute curse. I mean, these are things that you do not relate to your eyes, and they can be referring to a subacute effect of glaucoma. What's the effect of nearsightedness? They're associated with glaucoma. This is a risk factor having in the open bank, and this is the most common of all of them. And the hypermetropy, which in general terms, these persons cannot see uh, very well. So, doctor, my apologies in following this line. It could be interesting. Let's say that I have a nearsightedness since I was young. Should I do a check for this before the age of 40? Of 40? Yes, because nearsightedness, it is not only related to glaucoma, but things. I'm going to give you an example. A patient with nearsightedness, they have more risk of retina detachment. So therefore, not only for the glaucoma, but for other conditions in the eye, they should go to the doctor once they are diagnosed with nearsightedness. They they should visit the doctor. And the fact that, I mean, we have nearsightedness which are accelerated. Is this a risk for other type of diseases or illnesses? Yes, of course, because there's one thing that is known like malign nearsightedness. I don't know if you have heard of this. This type of nearsightedness is degenerative. What we need to be clear about is that this is associated to the growth of the eye. So this type of nearsightedness uh, takes place in eyes that grow a lot, and therefore you may have a rupture or a disruption in a structure that is called uh, a membrane, because there may be a growth of abnormal vessels in the retina, and and this is why with this nearsightedness that are advancing uh, should talking about nearsightedness, uh, there are persons who have a surgery. Does this reduce the risk to? No, this is an eye that will still suffer this type of nearsightedness, and the same applies to a person with hyper nearsightedness. They still have the problem. So the surgery is not going to save us from the risk of having this type of disease. There are two questions that we can have, and they're really when we talk hypertension and diabetes, these are part of the pandemic. High blood hypertension and diabetes, will this imply a higher risk, and can this cause glaucoma? That's a very good question. They're closely related, and if hypertension, diabetes, and primary glaucoma, they're sharing the same age group, so they so those three diseases are connected. In terms of hypertension, we it is rare to see a secondary glaucoma, which includes vessels that are located in areas where they shouldn't be, and diabetic retinopathy that established vessels were, just to give you an example, they can get in this type of diabetics to get vessels in the drainage angle. And what happens if we have those those vessels? The aqueous humor cannot be drained. Thank you. And astigmatism, they're not related to the growth of the eye, but of the cornea, and which is the lens that we have in front of the eye, which is, I mean, it's like when you have a watch. So it is closely related to this, and not so much to the size of the eye. So it is not related to glaucoma. Contact lenses, is it a risk factor? Not for glaucoma. Contact lenses. This implies this implies hygiene issues, or to avoid ulcers when we have some diseases like keratoconus, where the cornea has a different shape. So they indicate that's where you need to use contact lenses. And if the patient has glaucoma, there wouldn't be any issues. A person having nearsightedness at the and if that this process decreases, but then when the person does the tests, the ocular pressure is high, and there's an early diagnosis of glaucoma, and then there's a medical treatment that you have indicated. What she is mentioning here, this reduction of the nearsightedness, does it is there a higher risk to have glaucoma? No. No, the nearsightedness is the predisposition of the place, regardless if it's -3, -2, -0.75. This this could be a an open glaucoma angle. Some kids are using eyeglasses for nearsightedness. Not necessarily. Uh, a a person can be near can have this type of situation since very early ages and not suffer any glaucoma. A person with a dry eye or a Sjogren syndrome, is this a candidate for glaucoma? Yes, as I mentioned, it limits the medical management due to the adherence to the treatment. And And if we're talking about a dry eye, a moderate or a severe dry eye, it's not limiting just to the use the eye drops, but the surgery. So this is something that we need to determine. We could use laser first, trying not to do a surgery because the ocular surface is not good. So we can have a laser or a minimum invasive surgery because the medical management in the traditional surgery may perhaps be something that will not be well tolerated. So before we move on to me, this is a very important question. If I have glaucoma and I am diagnosed and I'm having a good management and everything is good, apart from the checks and the controls, what can I do to make sure that my ocular health is better, to prevent this from progressing, apart from having a good adherence to the treatment? In glaucoma, this is the most important thing to do because the ocular loss is quite important. If we can control this, for sure there will be success in the treatment. But there are things. Just to give you an example, there's a that one of my patients, he is he's a music teacher, plays the trumpet. So the increase of the intra-abdominal pressure that he does in his work causes it increases the secondary intraocular pressure in a healthy patient. There are mechanisms to control this, and there are no damages due to glaucoma. He has an advanced glaucoma. He cannot see in one of the eyes, so we have stressed on him. He should be a professor, a teacher, but he shouldn't be exposing himself to this because it's because if you have just one eye good, and if you expose this to this eye, to this abdominal pressure, it could not be sufficient, and the disease or the illness can progress. Thank you. I'm going to give you another example. I have a patient here. She loves yoga and I diagnosed her with glaucoma. So we sat down, we tried. I mean, we tried to find the literature, and I said, I'm not going to prohibit the Pilates and yoga, but there are some exercises that you cannot do because you can increase your intraocular pressure, especially those when you have to stand on your head, and that implies protecting your health. So these are some specific examples. That's interesting. Thank you so much. At times, one may think that this is just medication, and these are. I have another three question. Kidney insufficiency and obesity. Do they have an influence on glaucoma? They're more related to they're they're related to hypertension and diabetes. This one is important, and it has to do with what you mentioned with our ocular health. What medications that we normally use for a flu or some illness can lead to glaucoma? That's important because there are many medications that are sold over the counter and we abuse, such as the corticoids. Corticoids have a significant relevance not only in glaucoma, but also in other eye diseases. Because at some point in time, whether if we have a susceptible patients, uh, they can actually they can actually affect the angle, and this is why we can see an increase on the intraocular pressure leading to glaucoma. So people with asthma and they can, yes, on the in Antioquia I have several young patients. I'm talking about patients of in their 20s with advanced glaucoma due to the poor management of allergies, uh, who as a child they were not followed up, and they developed a secondary glaucoma due to medications. Interesting. Uh, The medications used to Sjögren, as you indicated, do they increase glaucoma? Corticoids? Because at times, I mean, these these diseases for patients for self-immune diseases when they have this type of use of corticoids, it is good to attend to go to the ophthalmology at least every year. Thank you so much. Thank you so much for your patience. We are going to share this in the presentation in the Boomi blog. We have medical news. One of them has to do with the glaucoma. And first of all, thank you, Dr. Laura, uh, and to your clinic for the presentation. It's been interesting, and this is reflected in the questions. How interesting and how motivated people have been here. We had a lot of questions. But thank you so much. Thank you, Francisco. Thank you, Sura, as well. And thank you, Doctor, again. And I want to invite you at the end of the following month so that we can have a Boomy health talk. And thank you so much. Thank you, everyone, for the participation. Apologies for those of you who we couldn't answer the question. Thank you, Francisco. Thank you, all the attendees. Thank you, Bumi. And we will wait for you in the following month.